Welcome back to the hysteroscopy series. This is a hysteroscopic removal of an IUCD due to absent strings on examination. As you can see, I've visualized the cervical lip and entered the cervical canal. But this looks very different. There are adhesions. The cervical rugae are not well defined in this case. So I take a step back and re-enter to make sure that I'm in the correct path. I ask the assistant to increase the pressure slightly, and as you can see, the pressure of the water is slowly separating the anterior and posterior walls of the cervical canal, but only till a certain point. Once the walls could not be separated with the water pressure, I decided to come back, reassess, make sure I'm not forming any false passage, and go back in. Once I went back in, I suddenly saw the transverse fibers which are keeping both the walls together. I decided to take a grasper because it is a blunt instrument and insert through those fibers. As you can see, I have found a passage. My grasper very easily went through it. So now I'm going to try to put my scope through this passage that I've formed. The scope was able to go in quite easily. I didn't face any resistance and I thought I'm inside the cavity. But as you can see, I can't really visualize anything. It was just blood. This was not very comfortable to look at. So I did decide to come out, come back, retrace my steps, and make sure I'm going in the right path. As you can see, we're back in the cervical canal. This is the level of the internal os at which the adhesions are present. I decided to put the grasper in again, but this time slightly above the previous level. Again, the grasper went in without any resistance, so I knew that the endometrial cavity is right there. And I knew I'm not in a false passage once I saw the opening of the endometrial cavity as a black hole, and I navigated my scope through it with some maneuvering. And here we are. Once I was inside the cavity, I realized there was a lot of trapped mucus, a lot of debris. The endometrium was really thinned out, basically atrophic because of the IUCD. This patient is a postmenopausal woman harboring the IUCD for over 15 years, which explains the presence of synechiae. A preoperative ultrasound is extremely important in such cases to make sure that the IUCD has not been displaced outside the uterus. As I kept getting a closer look at the cavity, I realized that my first entry was also inside the endometrial cavity just below the IUCD where a lot of blood was collected. Now I'm getting a closer look at the IUCD and the uterine interface. I want to make sure that the IUCD is not embedded anywhere. In case it is embedded, I would have to take a scissor and cut the adhesions. Flimsy adhesions can easily be separated with the scope, as you can see. Once I was sure that the IUCD was separate from the myometrium, I decided to put a grasper and grab the proximal most limb of the IUCD. Once I had a good grip on the limb, I asked my technician to not give any more pressure and I slowly removed the IUCD out. I'm using a 2.9 mm hysteroscope without any cervical dilatation. Some IUCDs may snap at this point or there might already be multiple pieces inside, so repeated attempts of removing all the parts may be required. In this case, we were lucky that after the initial entry into the cervix, everything was pretty smooth. As you can see, the entire IUCD has come intact. One last look is definitely warranted to make sure that no limbs or no piece of the IUCD is left inside. As you can see, the endometrial cavity is extremely clear. Thanks for watching.